Excellent. So it is lovely to be here. Thank you, Ruth, for the warm introduction, and really terrific to be here in person. I'm actually on sabbatical this year and spending time with Ruth and many others here as part of it. What I'm going to do in the next few minutes is really describe what's been an over 10-year journey of building a data platform to measure and evaluate the child and youth mental health system in Ontario, Canada. And I'd like to just reflect on some of the challenges, the opportunities, in particular for guiding policy, but also programming, with a bit of a lens around what's happened and some specific, I think, challenges and opportunities related to the pandemic and hopefully what will be pandemic recovery. Next slide, please. So just for a little bit of context, here is Canada. Little demographics, 37 million population, of which about 1.7 million will identify as either First Nations, Inuit, or Métis. So those are Indigenous peoples in Canada. We have about 6 million children under the age of 14. And there's a marker there for Ontario, which is a province in which I work, Canada's largest province, almost 40% of the population. We, as you do, have a publicly funded universal healthcare system, but the healthcare systems are largely and almost totally administered by each province, so 10 provinces and 3 territories. And while, basic services, primary care, hospital care, are fully funded, there are differences across provinces in terms of what's funded. And so one of the most stark examples is medications. So some provinces will fund all pharmaceuticals, others don't. And in terms of mental health, there's also differences in terms of some mental health services, cognitive behavioral therapy, psychotherapy, in terms of what is publicly funded and not. Next slide, please. So mental health system. Or non-systems. So, when you think about mental health services, and certainly, in our jurisdiction, there are so many players. There are services delivered in so many different venues to children and youth. So, obviously in primary care and specialty clinics, hospitals do a lot of mental health service work, but of course in schools, school psychologists, social workers, public health largely on the prevention side. And then in Ontario, we also have a whole community mental health sector, which deliver services, a lot of those sort of therapies, cognitive therapies, family therapy, as well as some residential therapy. And for many years, and I'll speak about this a little bit later, we're funded not by the Ministry of Health, but by a different ministry. And then we have a very large private sector. So psychologists, social workers, psychotherapists, many of whom are paid either out of pocket or by private insurance that families would have through insurance. Next slide, please. And then I really, I think an incredibly important context when we think about child and youth mental health is what happens at the age of transition. So in Ontario, it's age 18. And this is really what families and youth will describe as what happens to them when they turn 18. So many of the services that are provided by child psychiatrists, by the community sector that I mentioned, stop. And the other interesting piece is that general pediatricians actually provide a lot of mental health service delivery, and you just don't have that equivalent, like the internists don't do that. And so, at a period of time where so many mental health disorders emerge, of course, a developmental time that's very important, where young people are often moving out of the house, seeking employment or further education, the service delivery piece, is pretty bad. And we've kept this in our minds as we've thought about, the way in which we wanted to evaluate the mental health system. Next slide, please. So as a local context in the mid-2000s, we had 2 really damning reports on child and youth mental health services. One was federal that came out of the Mental Health Commission of Canada, and one was an Ontario-specific Auditor General's report. And really these reports highlighted, the very siloed nature of mental health service delivery. They highlighted the long wait times for services, but also the fact that there were very few standards, measures of quality, and really, no transparency as to what was happening in the system, certainly no accountability. Next slide, please. And so out of that, Ontario decided to launch a very large government-wide mental health strategy, 10-year strategy launched in 2011 called Open Minds, Healthy Minds. Next slide, please. And the first 3 years of this strategy were focused on children and youth. And this, and yes, researchers always say this is a busy slide, and I'm sorry, but this was just to give you a sense of this is the government strategy map. And really highlighting what they wanted to achieve in these first 3 years. And there were 3 main themes. The first theme was just providing faster access to service. The second was focused on early identification and intervention. And the third was focused on closing, gaps in service and mental health outcomes in vulnerable populations, and in particular in remote communities. And so this would be largely First Nations communities where there were huge mental health needs as a result of our terrible colonial practices and ongoing, funding challenges. So these were called out. And then the government already had a notion of what they were hoping to achieve. So that's that, those are all of those indicators in white. And again, just to say that some of these were very focused on the health system. So, government wanted to see fewer hospitalizations for mental health problems. They wanted to see less use of the emergency departments, or our A&Es, for mental health problems. But they also wanted to see, and of course they wanted to see outcomes move. They wanted to see lower suicide rates. But they also wanted to see, more distal outcomes, such as higher graduation rates, better school attainment. And then there were a series of initiatives, and so those are in the bottom, really funding envelopes, that were carried out by the three main ministries. So those were the Ministry of Health, the Ministry of Education, and at the time we had a children's ministry. And this children's ministry had the remit for the community-based mental health, the entire sector, child welfare, and also youth justice. And these 3 ministries were charged with moving on this strategy. And some of the funding envelopes were really discrete. So for instance, the Ministry of Health provided extra funding for hospital beds for patients with eating disorders, because we had not enough hospital capacity and we were sending patients down to the US for care, very expensive. And so some of it was really just narrowing some pretty discrete needs, the gaps in some needs, but others were definitely more transformational. So the community mental health sector, which was responsible for, many of the, much of the therapy that goes on, 440 agencies, most of which were paper-based, some of which only provided 1 or 2 programs. There was to be a transformation of that center to have lead agencies that would define catchment areas, manage wait times, bring the agencies, onto a digital platform, and then also, standardize the kinds of services that were being provided. There was also work that was done across the ministries, which, is actually harder than you think, and was, a very interesting learning for us. But things like the Ministry of Health funded nurses to go into schools. And again, not that easy to implement for a number of insurance and regulatory issues, but they wanted, the Ministry of Health wanted to work more closely with the education sector around mental health, supporting teachers, doing some direct care, and then also being a conduit to the community sector. So there was really, I would say, of all of the initiatives, really a mixture of some very discrete funding envelopes and others that were really trying to transform the system. And 2 pieces, and these are the ones that are circled, were about evaluation. So, and these were funded by the Ministry of Health, and they really wanted to have, measurable outcomes and a scorecard that was going to report on this whole initiative. So this is not program evaluation of each of the different initiatives, but this is really how is it all working together. And they also really wanted a strategy evaluation, and that's where we came in. Next slide, please. So Ruth mentioned this already, so who are we? So we're now called ICES. We used to be called the Institute for Clinical Evaluative Sciences. And this is a not-for-profit independent research institute. We have nodes in almost every university in Ontario. We're funded by the Ministry of Health. And we are named in privacy legislation that allows us to hold routinely collected health administrative data and use it for purposes of evaluation and system planning without consent. Next slide, please. So this slide really just shows we have a lot of data. We have that many records in part because our data go back to the 1980s, so that's why we have many more people present in the data than are currently resident in Ontario. Next slide. And just a few points I think that are germane about our data infrastructure. So, you know, many jurisdictions, pretty much all jurisdictions will collect, you know, hospital records, for instance, those administrative data. But we have, and it's been interesting in COVID to see some of the reporting that has come out of many jurisdictions that have hospital records. But we also, importantly, have a population backbone. So everybody who is eligible for healthcare, which is basically all legal residents, are in our data. And why that's important is because when you are using healthcare use data, sometimes it's actually really important to understand who's not using the data. And, you know, while you can put a denominator, you know, from a census to say this many children are using the data, and so we think these, you know, these number of children are not, it's actually really important to characterize those children. And so we have that backbone that's quite important. And we've brought a number of demographic data and linked in there, which are also important. So we have the federal immigration records that record all newcomers to Canada, be they immigrants or refugees. And then we've also worked in partnership with a number of Indigenous governance organizations around Indigenous identifiers, in particular First Nations who are registered and those who are registered as Métis. And we, you know, and we work with those data in a very different way than we work with other data, with different principles of governance, really driven by questions that come. But those, you know, also allow us to do work that is, you know, different than if you're just using the health data. And then the other piece is that we also have almost all healthcare delivery. So we are able to, you know, to go from somebody in primary care to see where they've used the A&E admission, gone back to see the specialist, back into primary care, and we can do that longitudinally. And that has been very, very helpful for us to sort of be able to understand the mental health system. Next slide, please. And again, I alluded to this before, but as we started to kind of wrap our arms around, you know, this remit of, you know, reporting and monitoring of the mental health system, we did, you know, need to spend some time thinking about which data we had. And we certainly, you know, had the traditional healthcare data and the data from physicians. The child and youth agencies at the time, 440, you know, most of those, as I said, not digitalized. There was, you know, we were not going to be able to integrate those data into what we were doing, but we did do some pilot work with one very large agency that had electronic records where the privacy legislation allowed it to do it, and was very helpful to understand how both the physician-led mental health system and the community-led therapy were interacting. New data for us were data from substance use agencies, and we integrated those. School boards, and you know, I'm part of the reason I'm here and so interested in all the work that Ruth and others have been leading on eChild is, you know, we really wanted to, you know, understand what was going on in the school sector. The service delivery, you know, the data on what the psychologists were doing in the schools was definitely not accessible, and we've had some hiccups that I think will be addressed, where it's clear that even, you know, data like on absence is so critical, I think, to measure what's happening around mental health, that we are still not able to integrate those, but that is coming. Next. So we launched on this, you know, journey, as I call it, of trying to do performance measurement. And, you know, the first bit I would call performance measurement 101, 1.0. And so we started to just do, you know, reports where we did a number of scorecards starting in 2015 and 17. And because the strategy was initially on children and youth, we separated them out. And then as the strategy moved into adults, we did one in adults and then across the lifespan. But one point that I want to make is that with that transition time that we thought was so important for all of the work that we did reporting on what was happening to children and youth, we always went up to 24, even though service delivery was cut off at 18. And for the adult work, we always started at age 16. So we just wanted to make sure that it was always clear what was going on in that transition era. And these reports, you know, I would say the data that we had, we used to get annually, always about 6 months lag. Then we would do these analyses. We did huge technical reports. We would interpret. And, you know, these were huge reports. And again, well received by some in government, but, you know, big and often outdated. And we've done some reflection, which I'll talk about a little bit more on how to modernize. Next slide, please. So in terms of the indicators that we wanted to measure, so, you know, the first time we reported, we thought, well, let's at least sort of give some estimates of prevalence, you know, how common is anxiety and depression in children and youth, which you can't just measure from healthcare use data because we know that there's a lot of unmet need. And it was quite shocking how little data we had. So there was a survey much older that had been done out of the Alfred Center by excellent scientists that was, you know, 20 years out of date. We now have a survey that from just before the pandemic hit. But, you know, wrapping your mind around how prevalent conditions are to really understand need was actually not that straightforward. We have lots of system use data, and we thought some of that was just contextual. So if somebody goes for a mental, you know, visits the GP for a mental health visit, what does that mean? Probably that they have a mental health, you know, there's some need, but they also have access. And so some of that to us was just, you know, context, but some of the healthcare use data can certainly be, or at least we thought, you know, could be considered outcomes. So for instance, emergency department visits for self-harm. To us, that was sort of, we're using the healthcare data, but those are outcomes. In terms of the performance indicators, which is part of what we were supposed to be doing, you know, not straightforward. So how do you measure access? You know, use is not the same as access, and really you have to ask people whether they have access. But there were a few indicators that we thought would relate to access. So, you know, by guidelines, when children and youth are admitted for mental health disorders, they should have a follow-up visit within a week. And if they're not, then to us, that was a measure of access. Quality, when you don't have clinically rich data, is very, again, difficult to measure. So we had some, you know, measures that were feasible, things like recidivism rates, you know, so readmission rates, bounce backs to the emergency department. But I would say, you know, not the ones that you would use if you were, you know, had all the data in the world accessible to you. And then early identification, which was again a huge theme of what we were, you know, what the strategy was going to be doing, also not easy because it's hard to know when children start to have the need for services. But one measure, and again, there was a huge focus on what was going on in emergency departments, is that we thought that, you know, to look at children and youth who present to the emergency department and have never been seen before, you know, that, you know, might reflect, you know, a lack of early identification. Next slide. So, you know, what did we learn from, you know, all the work that we did? So we definitely learned a lot about data. We learned quite a bit about the mental health system or non-system. We, you know, did deeper work with papers to understand the meaning of indicators. I think we became pretty cognizant of the challenges that we were going to have in evaluating a strategy. And we did, you know, we certainly learned a lot about the utility of reports and formats of reports. Next slide, please. So what did we learn about the data? You know, many sectors not represented, very important sectors, and, you know, there's variable, and when you're working with these data, and many of you I know do, you know, variable quality of data. And so in particular, outpatient diagnoses, at least in our data, are terrible. So, you know, and that's very important. So we do not hang our hat on a diagnosis of depression and anxiety if it's only coming from outpatient data, and that limits to a certain degree what you can do. Next slide, please. And what we learned about the mental health system, and, you know, honestly, I could probably talk for hours about this, but, you know, a few sort of high, you know, important things. So the first is that in our system, the largest inequities and the largest mismatch of needs and services are actually geographic for us, not as much sort of socioeconomic or only socioeconomic. We definitely saw that the transitions between what goes on in the acute care sector in hospitals, both emergency departments and admissions, and outpatient care are very poor. And we also just saw incredibly strong trends over time of just more and more care seeking. And this was, you know, really made it difficult for us to disentangle the impact of the strategy from other influences. Some of this was not unexpected. We did logic models of the strategy, and, you know, if you're going into a strategy where you're trying to improve early identification, reduce stigma, educate teachers about, what to look for in children. We actually thought we would see more healthcare service use, but I think what we ended up, discovering around what we saw over time was much more than just reducing stigma and seeing children and youth earlier. Next slide, please. So just, to highlight a few things, and this was just from our really baseline scorecard. So the geography in there are the two northern regional health regions in Ontario. At the time that we initially did our work, we had 14 regional health authorities. Those have been disbanded. It's a whole topic in and of itself. But at the time there were 14, and these are the two northern ones. And it was known, although the numbers hadn't been documented before, but we, as we started to look at trends, we understood, first of all, that suicide rates much higher in the north, and again reflecting in part specific mental health needs within First Nations communities, but that also over time, so as we were starting to do the first scorecard and we had looked back, really not a lot of change in the north, and in one of the regions actually a doubling, whereas in other regions, in some of the more urban areas, we were seeing drops in suicide rates. So that was very important. Next slide, please. And then in terms of how we sort of tried to match or understand the match between need, and suicide is obviously, depicts like important need, but we also, again, just looked at things like, regions with high emergency department visits, admissions, and then, physician visits, either after admission or physician visits overall. And this is now a map of all of Ontario and the 14 regions, the north, because it's so high up, we always just put in a little box. But essentially what you can see is, the regions where you have the highest rates of use of emergency rooms, high rates of admission, have the lowest rates of any kind of physician services, even when you include, telepsychiatry and others. Next slide, please. We also, on all of the metrics that we said were probably related to quality and access, we actually, as a strategy went on, ended up seeing everything kind of move in the wrong direction. So unscheduled emergency return visits to the emergency room, increasing 30-day readmissions, and really not a lot of movement in terms of the connection between follow-up care and those who have been admitted. Next slide, please. And then we really also, began to understand, because again, we were pushed very quickly to come up with a set of indicators. We had done lit searches, we'd looked at what others were doing, but a lot of what we had to do was, based on feasibility. So, I wouldn't say we made them up, but, we certainly sort of put some constructs out there, not completely knowing what they represented. So this was this indicator that I mentioned before around how many children who show up at an E&E for a mental health problem have ever been seen for a mental health problem. And so the first thing is that it's over 50%. So this is like a widespread issue. And as we dug down and really, started to try to understand, what this was about, some of this was about after hours care. So much more common in visits that were happening on weekends or after hours. No surprise that those who don't have a very strong affiliation to primary care or who live in rural areas where there are issues with access to primary care, that those children were more likely. But also some really interesting demographic ones. So immigrants and refugees, even if they had very strong affiliation with primary care, most live in urban areas, and had good relationships with primary care, they were more likely to show up in crisis to an emergency room. And we did subsequent work also to understand, some of the region of origin and regions where mental health is much more highly stigmatized than others. But the other interesting thing that we found is that even for children who, again, had good affiliation, were regularly seen by their GPs or primary care pediatricians, for those who were seen in practices where the primary care physicians didn't do a lot of mental health service work, they were more likely to also basically have their first contact in an emergency department. And so a lot of that was fed into other initiatives that were by the Royal Colleges that were thinking about training of primary care doctors around child and youth mental health. Next slide, please. Over time, and this is from one of the last reports that we did, where we did it across the ages, we just saw just overall across the board, more use, more use, more use. So outpatient visits overall 9% increase, but 58% increase in youth, 14 to 17, almost the same in young adults. Emergency department visits, increasing, and very, very high increases in youth and young adults. Same for hospitalizations. All of these increases were really, really driven by children and youth. Similarly, self-harm. So suicide has been relatively stable, but self-harm increases really driven by young people. Next slide, please. And the increasing rates of emergency departments, were a very visible and high-profile issue. So as you recall, the government itself said, this is something we don't want. We want to see those emergency room visits going down. This is one of our metrics. So this graph shows what happened to emergency department visits. They're by acuity. So the light blue are low acuity visits, things that could potentially be seen in outpatient settings, but higher ones you could see in dark blue. And clear inflection point around 2009. There you can see where the strategy went into effect. And if you would continue that, sort of just a continuing increase. And, this became the subject of another Auditor General's report, because there had been, hundreds of millions of dollars put into this strategy with the aim of reducing emergency department visits. And, the Auditor General was sort of, what wanted to understand what was happening. So next slide. So we did some work to try to understand this, and essentially, what we showed was these emergency department visits. The greatest increases were for anxiety and mood disorders. Much starker increases in females, and that these, and I already showed you by the acuity, but even looking at measures of whether or not they needed to be admitted. And measures of what they were being seen for instance, self-harm, were increasing. We also showed this was not, this was not the case with other things presenting to the emergency department. So this wasn't all of a sudden because, there was no access to primary care and everybody's showing up in the emergency department. And we showed, this was not related to any sort of decreases in mental health use within primary care. So there's clearly, something else going on. Next slide, please. And interestingly, at the time that we wrote the paper about it in the report, we couldn't find data from so many other jurisdictions. There were some data from the US, the CDC had reported, but nothing really in the peer review literature. But since COVID, and there's been such an interest in, child and youth mental health, they have gone back to similar time periods and shown this to be the case. Canada, US, and Australia. I couldn't find anything from England. Next slide. But also, other jurisdictions using other kinds of data have seen this. So Jean Twenge is a psychologist in the US who does really brilliant work. There's a population, a representative sample of school-age children where they survey every year. And what she found, so on your left, so this is by year, males and females. These outcomes are depressive symptomatology, suicidal ideation, and suicide rates, although those rates don't play in as strongly. And you can see, similar to what we saw in girls, just this incredible increase in the symptomatology based on the survey, and a very similar inflection point. And that inflection point, 2008, 2009, so there were two competing sort of hypotheses around this. One was the financial crisis, which hit the US much more strongly than it did Canada for a number of reasons, and then social media, of course. And, her work has also, so on the next figure over there, shown, very important associations between many of the risk factors and suicidal ideation and depression with screen time. Now, these are associations. These are not, it's association, not causation. And of course, there could be reverse causality, but I think, very important work suggesting that there are large societal trends that are driving much of what we're seeing. Next slide, please. So just taking a little bit of stock, and we were actually doing this right before the pandemic hit. We understood that there were, and the ministries understood there were limits to what we could do to, evaluate this pretty complex strategy. We took a lot of stock around our reports. I mean, we were turning these out. They were certainly welcomed by government. They were our deliverables, but we weren't sure, how many other people were really using the data. We started to really think about how could we use our data more to mobilize change. And then we had a really interesting policy environment that changed, which brought opportunities and challenges. So I mentioned we had a change of government. That Ministry of Children was blown apart, and the mental health went into the Ministry of Health, and juvenile justice went into the Justice Department. And so there were sort of opportunities in bringing some of the sector, at least under one ministry, with the data people that went. And the other was that our regional health authorities were disbanded, but a lot of the thinking was that the level of accountability within our health system should be more like what they're doing in the US with accountable care organizations. And those are really organizations where you have a hospital system and you have specialists in primary care who are responsible sort of for a population. And that's one way. And in the US, they can do it because of their, the way their insurance works, but that, some of the accountability for what we saw is like really poor transitions between, those sectors, could be strengthened if administratively we're sort of all working together. And that was a huge policy initiative that we thought was probably going to be a good thing. And then next slide. And then COVID happened. And, really everything else got put aside. But COVID actually, and I could have spoken the entire time about, mental health and COVID, but COVID actually made us, and what happened during COVID and how our data were used, really made us, continue to make us reflect on where our data could be helpful, but where there were some limitations. Next slide. So just, I would say COVID pushed us into performance measurement 2.0. And interestingly, we've been reflecting on these big reports, the fact that we would get the data annually and all the work that we would do. So the other side of the shop at ICS, we were starting to get real-time data on COVID testing. Like we got daily reports. And for the first piece of the pandemic, because of some of our other data holdings, because of our capacity to do the natural language processing to, understand the results, but also the linkages to other data that we had, nursing homes, people with chronic conditions and all that. We were doing daily reporting for a while, then weekly reporting. And we just became, for the first time, like we'd never had real-time data for anything. And we just, and we needed to do that. It was, and it just switched our thinking about how we could use our data. Because we didn't, prior to that, do a lot of routine reporting with the exception of these massive reports that we had been doing. And so, it made us think on the mental health side too, if we can do that, for COVID, we should be able to do this for the mental health data. And part of what we did was we started to get data more frequently, in part to do the COVID work, but that also allowed us to operationalize much of the reporting in a more timely way. We are not brilliant at data visualization, but we did sort of get with the 21st century and have a bit of a platform. So we're using Tableau so that we would just have interactive data, and we just started to put the data out there. So no more, lots of interpretation and all of that. Next slide. So just to show, this is, one of the, this is just straight from our Tableau. You could pick ages, sex, you can pick method of self-injury. So this is for emergency department presentations for self-injury. We have some sociodemographic ones. And so we just started to sort of put the data out there in a more timely way. I picked in red 14 and 17, and then in dark blue, young adults 18 to 21, just to show you, and you can see, what was happening there. And then of course, the fact that we were getting data more frequently also meant that we could do proper papers where we would take into account time trends and do these with proper models, also meant that we were able to do work in a pretty timely way. Next slide. The other thing we were able to do was, address a lot of concerns that were coming from the sector. So, I mean, there were, and many of the children's hospitals were, really raising the alarm about children's mental health based on what they were able to see. And so, it was clear that, no, it's fine, you can go to the next slide. that was important. And so here, is some early work that we did. We were hearing very early on about eating disorders and the need for, care. So this is actually from the proper paper where we did take into account, the model. So we have the expected over observed, and you can see where the icon of COVID is, that, very shortly after we were starting to see much higher rates of emergency department visits. I could have shown hospitalizations for eating disorders than what you would expect from, the last 3 years and seasonality. Next slide. And then the other thing we could do as well, and which is different than some jurisdictions, and particularly the US that actually does a lot of this kind of reporting just from data from children's hospitals, is that we were also able to understand what was happening across the ages. And so here, these are the hospitalizations. I could have put eating emergency department visits, but in red, you can see 10 to 17-year-olds and the huge increase in what we observed versus expected, which is dotted lines, whereas in other ages, really pretty flat. Next slide. And again, of course, members of our team wrote papers and, added to what's been, an incredible literature and an incredibly consistent effect across jurisdictions, despite very different pandemic-related restrictions, school restrictions, and all of that. But for us locally, this was actually really important that we were able to, do some of these data analyses quickly, because what it meant is we, that additional funding for hospital beds, again, was secured for eating disorders. So, the role of kind of the local data informing what needs to happen locally, as well as adding to sort of a wider literature, is very important. Next slide. The other piece that I think our data have been helpful with during the pandemic is that the children's hospitals, really were raising the alarm very appropriately, advocating for children and youth, but they were doing it based on their own data. And these are data from children's hospitals in green, and then blue is all other hospitals. And these are emergency department visits for mental health problems in children and youth. And what you can see is, the vast majority of children are not seen in children's hospitals. But what we also started to see was that there was a huge drop-off in care seeking to other hospitals. And this stands to reason. These other hospitals were swamped with COVID and swamped with adults having COVID. And so there were actually changes in where children were seeking care. And so what we were seeing in the pediatric sector was actually not true of the entire system. And that was true both of around mental health, but actually also child abuse. And so it was just really important to be able to put some system level data around that to really understand where there were increases and not. Next slide, please. So, COVID highlighted to us, some of the strengths and limitations of our data. We certainly, and I think this is, it's still, an untold story. Early in the pandemic, we actually, with the exception of eating disorders, most other mental health problems and the healthcare use for it went down. And again, that was different than other studies that were using different data sources, usually not population-based. And so we saw different signals. And I think it's still unclear whether what we were seeing was a result of just a huge disruption of the healthcare system. So lots of unmet need that just was not coming to care versus actually, less need. The other thing, of course, that I just mentioned, our data are full system data, and I think that is helpful, and lots more to come. So, and we have teams, working on this, and I think the sort of full picture of certainly the why, but also, what has happened to some of the other trends that I spoke about in terms of anxiety, also depression, how we will come out of the pandemic into recovery, I think is still, not totally clear, and I think requires data from lots of different sources. Next slide. So a few new horizons to end with. Next slide. One piece of work that we're doing is, around virtual care, potentially a silver lining to this pandemic. So the majority of mental health care now is being provided virtually, and we have lots of team members doing great work to understand what this means, who's accessing, have we been able to actually, some of the geographic disparities that I've shown, have we been able to address some of those, and for whom is virtual care working? So lots and lots of work to come, and I think will be actually quite helpful in terms of, how the system looks moving forward. Next. So the other thing that we've been very interested in is really sort of starting to think about much deeper data and clinical data that really is important for understanding service delivery. And I bring up I mean, I'm sure all of you are familiar with the IAPT. It comes from here. I can tell you from the outside, this is seen as internationally the example of how to roll out therapy, like evidence-based therapy, training, workforce development, and data. And as I mentioned, the strategy after the first 3 years moved to adults. And so Ontario has been moving to emulate this program of funded psychotherapy, structured therapy, in adults. And so we've been a little bit more focused on the adult program rather than the children's program here. Next slide. And in particular, we've just been very impressed by, the digital platform and the fact that data are collected at every encounter, and that those data are then captured centrally, and they are used both for that patient in terms of their care. They're used to do quality improvement. So some hubs seem to be doing better, seeing more improvement than others. So being able to use that, but then also for that piece around accountability, which is what we're also doing. So we think this is totally the way to go. We are trying to emulate this. I would love to see this also being rolled out in the children's sector, although it's going to be much more complicated again because of how many different venues of care there are. Next. And then the other place that I think our data are really starting to be very useful is around regional planning. And so this is around, this slide just is around early psychosis programs. So we know, there is incredible evidence that intervening early when youth and young adults present for the first time with psychosis is incredibly important. It makes a huge difference to outcomes, including mortality. And Ontario has developed now a network of early psychosis programs. But psychosis is not, rates of psychosis are not the same in the population, and we've been able to use our data to sort of put numbers around their catchment areas, but then also starting to understand which catchment areas are covering everybody and not. So how many people are actually seeking care in these programs. So understanding which regions, there needs to be sort of a push to make sure that these programs are accessible. And I think this is a really great way that, our data are being used to make a difference at the program level. Next slide. And then finally, we're always interested in new data. Again, I mentioned I'm here, and learning from Ruth and Katie and others, really about, some of the ways to work with education data, child welfare data, and hoping that we can sort of move, I joke we might call it eChild Ontario, but really, it's very impressive work here, and we know we want to go there. And then also, trying to get a handle on some of the community-based therapy data. Next slide, last slide. So really, we continue marching on with this work. Data stewardship's a big part of it, research and evaluation. And again, I think, the pandemic, I'm hoping, and post-pandemic recovery has sharpened the policy focus on children and youth and mental health, because it certainly in our jurisdiction waned a little bit once the strategy was off of children and youth. And I think it's an opportunity for us to put it back on the agenda. And again, we're doing lots of work both with governance organizations like the Chief of Ontario, but also individual Indigenous communities around some of their data and partnerships around moving forward. And last one, and then of course, these are huge team efforts, and especially I'll call out my colleague Paul Kurdiak, who's an adult psychiatrist with whom we've co-led the work and who actually is now leading a lot of the implementation of these programs within the province, and all the other team members who have contributed to